Hello everybody, welcome to our board meeting in March, and to anybody watching us, we hope you find what we discussed today of interest as we look at a range of activities but also performance and finance reports and outcomes across Humber Teaching NHS Foundation Trust. I'm Caroline Flint, the chair. Can we start with apologies, and I have apologies from Stella Jackson and Stuart McKinnon Evans. I don't think there are any other apologies for this meeting from that I've been notified of. Declarations of interest. Are there any changes to the declarations of interest? If there are, please let Laura know in the board support unit. And if there are any other conflicts in terms of your declaration of interest with any items, please make that known before we start on that particular item. Okay. Minutes of the meeting held on the 29th of January, are they a correct record? Approval for that, thank you very much, that's approved. Any matters arising, and let's include the action log in this and work plan. Any comments in relation to that? No, okay then. So we move on now to our patient staff story. I'm really delighted to have colleagues here today with us who are going, Samantha and let me have a look, Lisa as well, I think are involved in this item. Welcome. We're really interested to hear about the work you're doing and what's happening and some of the outcomes for service users. So I don't know whether a lead member of the EMT want to say anything before we start, but you're very welcome. And over to you.
Caroline, we've got a few more members of the team here.
Sorry, have we more? Have we got Justine here as well?
We have got Justine, we've got Anna.
And Nikki.
Yes, as well.
Oh, sorry, my apologies. Sorry, apologies. Sorry.
No
worries. A cast of thousands, that's fantastic.
Yeah.
So I don't want to feel like I'm leaving anyone out. Okay, all right then. Right. I had Justine and Nikki down, but I didn't have Samantha and I think Lisa down. And therefore, when I saw Samantha and Lisa first, I thought there might have been a swap. So that was my wrong interpretation. Over to all of you. We look forward
thank you, Caroline. And Nikki would have liked to have been here, but unfortunately, she's off today. So we aren't.
Okay, fine. My mistake.
Do we need to introduce people, or are we taking that yeah, you're interested? So Lisa, Sam and Anna, I think most people know me because I've been to board before. I'm Justine Rook, but I'll introduce Lisa, Anna and Sam.
Yeah, I'm Lisa Weldrick. I'm the team leader for the Hull and East Riding CAMHS Community Eating Disorder Service.
Welcome.
I'm Anna Doughty. I'm consultant clinical psychologist for the service.
Morning, Sam Mackenzie. I'm the clinical lead for all of our children's services in Humber.
Thank you all. We're just going to go straight into a small presentation that we've done together, and then what we'll do is we're going to listen to Lisa and Anna, who are really going to bring this service to life through some of their patient experience stories and experience of developing this team. So I will share my screen. Okay. Go on to slideshow. You see that?
Yes.
Is that coming up? Okay, lovely. Thanks, everyone. So as I say, Nikki would have been here. Nikki's the service manager of this team, and we'd hope Nikki be here to do the background, but Nikki's off, so I'm going to fill in for Nikki. So very quickly, the rise of the need for the EDIT team really came alongside the rise of eating disorders that we were seeing within the general population way back, really as far back probably as 2016-17. However, what created a perfect storm around that was the onset of the pandemic. It created a whole lived experience for young people around uncertainty, fear, loss of control, disruption, and we saw the referrals into the eating disorder team soar. Alongside that, some of that growing awareness that once a young person was admitted into an inpatient unit, the outcomes for them longer term were really quite poor because they were pulled away from those support networks around their family and the communities as well. So there's an emerging evidence base around that, alongside the fact that once they were admitted, they tended to become their presentation deteriorated, often resulting in them needing NG feeding, which led to very long admissions. So Lisa, Anna and the team, well aware, really ready actually, and really aware of the evidence base of what was emerging around those national drivers, put together a successful bid that we applied for from NHS England for 1 year's funding for the service, which was very clinically led, bottom up, and grown with all that emerging, say, evidence base. The team went live on the 1st of December, and I'm going to not go any more into that because Lisa and Anna are going to really bring that part to life and show their passion and commitment. But just before we do, for the sake of not taking slides down and sharing, having to reshare, we're going to just present this slide, which it details all the progress that we've made against the aims and objectives that we set out to achieve with the EDIT service. Those you'll get the copy of the presentation. You can see some of those, but just to capture it for you to see now, what this slide shows is the rise of eating disorder referrals that have come into the service. So showing a 44% increase. The blue slides are this year. The pink slides are the years before that. This data as well, we do believe it is across the ICB, so it's not just around our service, but we were seeing that ourselves, that 44% increase. And this is one slide that shows the reduction in those out of area cases, again, across the ICB, but within our own service. You can just see how that pressure on those out of area cases has been removed, which is brilliant. And to date, we've only got one young person in a SEDU, which is a real specialist area of eating disorder unit that's required. And that actually is because that young person is 12, so is unable to be in an Inspire. So at that point, I'm going to hand over to Lisa and Anna to really bring this to life.
Hi everyone. Yeah, thanks for the opportunity to come and talk with you. I think I just wanted to add that, you know, we feel that, you know, we are now in a really sort of fortunate position to offer the whole eating disorder pathway to young people and their families. So as well as the main eating disorder team that's been sort of well established for a number of years, and that really is the sort of foundation and basis of all interventions, are really well established and successful sort of in its own right. We can offer now both local inpatient and intensive, mainly home-based interventions to help prevent and reduce the length of inpatient stays. We work really closely and successfully with our paediatric colleagues at Hull Royal. We've worked really hard at that. And because of that, we feel that I think the service that we provide to families is the most effective and sort of locally based service. And I think just to reflect that, what I wanted to share, we get loads of feedback, we get loads of letters, we get loads of lovely cards. And I think just to sort of bring this to life, really, some of the sort of patient feedback that we get. So I'm just going to take some snippets from some cards. So thank you for never giving up on me. You have continued to encourage me and never stopped believing in me. Thank you for pushing me to explore the parts of my brain I've turned a blind eye to for so long. Thank you for always showing up in whichever way I needed. So that was from a young person specifically. We have poems and very sort of creative pictures that are sent to us. This is from another young person. You've seen me unwell, you've seen me sad, you've seen me angry and also mad. I want to say thank you for everything. If it wasn't for you, I don't know how ill I'd be today. And this one is particularly, if I can get through this without sort of my voice breaking, I shall try, because it's really quite emotive, this one. When we first met you and your colleagues, it felt like an impossible task to get to where we are today. Yet here we are. You have been amazing at getting the best out of our daughter. She came to you so very poorly and leaves you today as a strong, healthy young woman. You have given us our daughter back. I just think that says so much. And yeah, just pass across to Anna.
So I thought I'd just talk a little bit about the team and what Lisa and I have tried to build up over the past, across the whole service, really. Obviously in the last 18 months or slightly less for EDIT, but that's been a continuation of what we've built up for the main eating disorder team that's been going a little bit longer. And I was thinking about the team culture and what we've really tried to focus on and create. And really, I think there are 4 C's that sum it up. So the first one being commitment. We have a real commitment to each other and a real commitment to the families and young people that we work with. You know, we work as a team, we rely on each other, we have a real sense of duty to each other and being there for each other in terms of the staff group. We have clear roles and responsibilities. We really do work as a team, you know, that reliance on each other. We're not independent practitioners who go off and do their own thing. We spend a lot of time, we do a lot of co-working, we do an awful lot of reflective practice, we do a lot of team discussions. There are spaces throughout the week for people to get together and really understand some of the struggles that we're facing as staff and supporting each other. The second C is context. We really do believe, and as part of the really clear clinical model that we operate to work effectively and bring about lasting change for individuals who are really struggling and families, we have to understand their wider worlds and we have to understand the influences that are around for them. An eating disorder just has such a powerful effect on everybody. So the context and understanding families as a whole and the context of the families as well, so it keeps going wider and wider, is absolutely key to the work that we do, that systemic approach. The third C is connection. I think if you talk to anybody in the team, they would say that our biggest resource is the relationships that we build with people, whether that's young people and parents or whether that's again with each other. So we're really focused on how we engage, how families experience us, how they begin to trust us, how responsive we are. We go over and we go beyond, really, I think. And I think I can safely say that every member of the team would you know, show you that commitment in terms of how important relationships are for our work. And then the fourth C is care. And I suppose it's just to say that we really do believe that everything we do matters. And I hope that comes through in the feedback that you've just heard.
Thanks, everybody. I think that rather than put the slideshow back up, I think that concludes the presentation that we're about to deliver, but we've given hopefully lots of time for any questions.
Thanks very much, Justine. Thanks, Anna and Lisa. I'm sure there's lots of questions here. Could I just start off by just sort of particularly for the non-executive directors, maybe a little bit more understanding around. I know there's in the paper ARFID, and that's avoidant restrictive food intake disorder. Is that quite a new word in this space from what we were used to? And, you know, presumably there are different issues within that for people who you're working with about their relationship with food. Could you just tell us a little bit more about that?
You want me to do that?
Please.
Yeah, so ARFID is a new phrase, a new term, and it's a challenge. You know, these young people have been around forever. It's not a new presentation, but it's a new description of some of the young people that we see, and it's like it really is an umbrella term. So it encompasses a whole range of different young people and populations, actually, which makes it a real challenge to think about what kind of service is needed. So it incorporates, you know, if you had a young person who had a phobia of swallowing, and that meant that they were restricting their eating, that would be an example of an ARFID, you know, descriptive. You would use an ARFID description for that. Similarly, if you have a young person who perhaps is on the autistic spectrum or has an ASC diagnosis, and their restricted eating was more about sensory issues and the textures of food, and then that would be an ARFID, potentially an ARFID diagnosis as well. So you can see from that the resources needed and the scope of any service is really quite broad and really quite wide. And it's a real challenge across the country. You know, there's lots of conversations about what would an ARFID service look like. Within our team, we do see young people with ARFID. We were never commissioned for that. And because of the explosion in these numbers, it's becoming a real challenge. What we've agreed is, because these young people can get incredibly poorly, we will see those extreme cases that we're really concerned about from a physical health point of view. And what we're trying to do is pull different services together to create a broader service which will support people who perhaps aren't at that extreme. And that means I think we're going to go for a model which is working out into other services to skill them up, so that it isn't about everyone coming into us, but we can kind of share our skill and resource and really develop a kind of a pulling together around some of these young people and their families, because again, the family work is absolutely essential. Parents have been struggling for years sometimes to feed their kids, and there's so much anxiety around that. A family-based model is going to be really, really important.
Thanks, Anna, for that, because that's just to clarify for me something in the paper as well. And there's no commission pathways for that, whereas the work you're doing, thankfully, has got recurrent funding, which is a great testimony to your work. Thank you. I've got Priyanka. Please show me a hand if you'd like to make a comment or ask a question. Priyanka. Priyanka, you're on mute.
Hello, thank you. Thank you very much for the presentation. It was very heartening to see how your work has affected families. It's really important. And being like having children and grandchildren myself, and I know how families struggle with this sort of problems, and then they lead on to other mental health issues when this goes on. And my question is, first of all, to thank you. You've done a real good job. We can see that from the feedback. And you mentioned that you had achieved like 1 year's funding. So after that is over, so is there any way of supporting these services? Is it going to come from the normal budget? So how do you sort of think about continuing this great service?
Oh, shall I answer that one? Priyanka, yeah, the bid from NHS England was just as the pilot. We have received, confirmation of recurrent funding. So the team now is established and will continue. It was a sort of a proof of concept. And I think you can see from the outcomes that's been achieved, the concepts worked really, really well. Yeah, I think one of the things we probably haven't said so much through the presentation is around this service being a real alternative to an admission into an inpatient unit as well. So just wanted to mention that while we're there, because it's very difficult to prove that you've prevented something. But that data for me just speaks volumes to the testimony of this team. Hence its continued funding. Thank you.
Thank you.
Nice to see a successful pilot turn into a reality. Doesn't always happen. Dean.
Yeah, thank you. Thank you for the update. So I'm Dean. I'm one of the non-executive directors, and we have a number of patient stories at the start of these meetings. And one of the things that seems common to me in terms of the people that we look after and care for is it is sometimes indistinct, isn't it, in terms of what the outcome is and when it will be, compared to many aspects of physical health, which are much more known to people. So thank you. I think it was people move around the screen as you speak, but I think it was Justine that was reading out the stories, and I think people can definitely relate, to that sort of aspect that you put there. And again, it's brilliant that we have, compassionate staff that are still moved despite caring so much for people, but they see that day in, day. So thank you for that coming across. My particular question was really about, this may be my observation rather than a fact, but we see increasingly, don't we, these sorts of conditions moving into adulthood as well. And I just wondered about the transition from that children and young person care and family into the adult sort of aspects of care, and whether we do that well or anything that we could be doing differently or better.
Can I respond to that one? Actually, surprisingly, we do manage to discharge lots and lots of young people before they reach adulthood, and I think that's the testament to the work that we do with the young people and with the families, and how how much, I guess, time and effort and input that we give to that. So we transition very few young people at the point of 18. There are differences in relation to Hull and East Riding in provisions. You know, Hull has a very well established within CHCP. They have an adult eating disorder service, and there's some commissioned elements for an East Riding service that Evolve pick up. But I think the predominant message is that we work really hard. We work really, really hard to help young people not move into adult services. And our transition rates, I think, reflect that.
I think the bit I'd add on is that we are doing a lot of work across the trust in terms of transition to adult mental health services. So we do have some really robust structures to make sure that that is really safe and effective when we can do it. I think one thing that this team do really well is where they do know that they need to transition somebody, they plan really far ahead with that, and they're thinking and they're doing that really carefully rather than waiting until somebody's nearly 18 and going, oh, what do we do now? But I think the main bit is that trying to support young people to move out of mental health services before they hit adulthood and go and live their lives. And I think the other thing that I intended to say there was that this isn't a team that'll go, oh, you're 18, now off you go. They'll support people into their 18th year longer if they need to be able to complete that piece of work and let people go off and live the lives that they want to live. So I think transitions are managed particularly well in this area, despite the fact that maybe the resources aren't as widely available in adult services.
Just to say as well, there is a lot of talk nationally about all age eating disorder services, so that the transitions aren't, you know, such a kind of sticky point. So there are conversations happening, and there are examples across the country, but sometimes when you look past them, it feels like they are actually separate services still. So that all age service is a little bit of a misnomer sometimes. I'm not saying for all of them, but yeah, certainly it's something we're thinking about, but we aren't there with that.
Okay, thank you. Phil?
Yeah, thank you for your presentation, your commitment to the service, and more importantly, probably to the patients shines through. So thank you very much. I'm just trying to learn a little bit. Obviously, you've got a commissioned service now. That's great. But are there any sort of eating conditions or conditions around eating disorders that are out of scope for you, and what happens to those patients if there are any?
I would say it's that new term of ARFID, which in some ways
just the ARFID, yes, yeah,
and unfortunately, I think because it's been given this new label, what's happening is services across the board are saying, oh, that's ARFID, that's new, we're not commissioned for that, and we don't have the skills to work with it. And actually, I would argue that people do have the skills, but it's become quite a challenge. So we are trying to get hold of that across, regionally. There's lots of conversations, but I would say ARFID is the biggest.
Right. Thank you.
Group. Yeah.
Thanks very much, Phil. Lynn.
Thank you, Caroline. I was actually going to ask the team to pick up that issue that Dean raised around transitions, but that's already covered. Just going back to the point that Justine was raising, I really do think on this occasion we are seeing a significant transformation of these pathways for eating disorders for children and young people. 2 years ago, barely a week went by where I wasn't having and receiving escalations from the acute hospital, for example, of children in paediatric beds. Quite rightly, they were right to make those escalations. Those children's needs weren't being met when they were overstaying in paediatric beds. And obviously the impact on children and young people and their families of being in the wrong place, I think we just can't underestimate the impact of that, the distress that it caused. So we really are seeing a transformed service with this intensive community offer, and with the developments in our Inspire Inpatient service as well. So it's a phenomenal difference. So I just thank the team for their comprehensive efforts. And we've received the resource because of the models we've been able to put forward. But for me as well, I know when you came to talk to us in the ENT as well, I think it's that outcomes as well that we need to keep focused on, demonstrating those, building on those. But my question to the team is, right, you are now where you are. If you have a sort of key next ambition, what would that be? And obviously you've got the ears of the board here to help and support you with that.
Oh, that's a good question. We're going to throw that one over to the team. I mean, Anna, for me, there's that thing, isn't there, around the ARFID, and like Anna said, people saying, look, purely it's not a commissioned service, isn't that okay? Because it's always been there, but it's about how we bring the pathways together across, you know, the acute services as well, the dietetics, all those services that we have, neurodiversity that impact on the ARFID, and we look at how we share that work across, you know, in a sort of multidisciplinary team, but with the support as well of Hull Royal. So that, to me, that real multi-agency team around the child approach would be what I'd like to see next.
That's helpful. Let's set that as our ambition, as you say, and let's, because we lead the way, don't we, in this work in our area. So thanks, Justine, that's helpful.
Michelle.
Yeah, good morning, everybody. Thank you so much for the presentation and the work that you're doing. At least for the stories were really emotional, and I know it's really good to hear those. I know that sometimes takes some real courage in reading them out, but I think it's really good to hear the outcome. Lynn's actually stolen my thunder in a way, because I was going to ask about the next step, so I won't do that. But I remember when we had a conversation in the Specialist Commissioning around what we wanted to do with the rise in demand in eating disorders. So it's really good to see 18 months, 2 years on, and just see what transformation we've made. And I meant you in the community. So it's really important to look at that next step and that interagency working, and we need to sort of try and facilitate that, because anything that we can do to keep people out of hospital, because like Lynn, I used to get phone calls from CEOs that were irate, and it rightly so, but it was more important that we move that young person and the families. I was just wondering, obviously building on the work around the challenge and the next steps, is there anything that's particularly, I'm going to use the word clunky, because I don't, and it's a poor word, but that we can help maybe unlock, because obviously we'll be developing relationships with place, we've got links in with Specialist Commissioning. Is there anything in order to achieve that challenge and that ambition for that multi-agency, etc., that we can do now, I think, to help facilitate that? Because obviously we've got some of the skills to be able to move some of the money around, and also can we share some of the outputs and the stories that we've got in that wider context? Because I think the more at the moment we share our experiences at hospital avoidance, the better, because that's obviously one of the key government targets, but also it's something that we should all be aspiring to. So there's a bit there, but I think you can Justine and Lisa and Anna and Sam, I think you get the understanding. So any thoughts?
Yeah, I feel like I've said a lot, but I'll just say this part and then open it up to the others as well. But it really is that real understanding of what's driving eating disorders out in the communities, and I think there's lots of theories around that, isn't there, around the rise of social media, the sort of lack of face-to-face contacts that people are having, young families and things like that. So really pushing that agenda upstream, and we've talked about it, Anna, haven't we, a lot. We've said, how do we get the message out to young people around that recognition of eating disorders early enough, so that we can nip it in the bud. And sometimes you look at things that happen when children come into the service, and you can see there's some missed opportunities. So it's just tracking it back and looking at where were those opportunities and what could we do to strengthen that up, to try and push that support much further upstream, to prevent the conditions becoming worse. But what we came up against was really, how do we get that message across to young people? Because what we didn't want to do was to talk a lot about eating disorders, because then we're actually giving out information about it, which could be seen as contributing to part of the problem. So it's a phenomenon I think we're still looking at, but certainly that upstream prevention.
Sorry, through the chair. So I think we need to do some work around that upstream piece of work, so we can think about how we do that, and maybe some research, because obviously we've got links into research and what have you. So it's a really good opportunity to work with the research networks at source to see if there's any funding that we can get through the universities to help us look at some research as well. So maybe we just badge all that together, but we can take that outside. But I think that's quite interesting, Justine. So thank you. I think you're on mute, Caroline.
Apologies. Priyanka.
I think my question was partly answered by the previous question that Michelle asked. But what I wanted to ask was, how did you sort of get the referrals that you got? Was it through the GPs? And if the public, they want to come to you, is there a direct method of doing so, or has it always got to go through your GP? Like the physiotherapists, they have like a self-referral scheme. So do you have anything like that, or is it coming through the GPs? And how do you get the people to come to you?
Question for Lisa.
Yeah, the main eating disorder team receives referrals from anywhere, so from young people, families, and we encourage that, because the families are the people that are living with it, and they know what's happening. So we absolutely encourage families just to literally pick up the phone and get in touch with us. Of course, we take referrals from professionals as well, within our own sort of CAMS service, from our colleagues in other teams. We provide consultation if an actual face-to-face assessment or treatment intervention isn't needed. So there's lots of sorts of routes. There's lots of routes in for us. But yeah, direct is our preference.
Yeah, is it advertised? Sorry, is it advertised? Well, I guess somewhere there?
Yeah, because we cover the whole of the Hull and East Riding, and it's tricky to sort of work to services change all the time, and GP practices change all the time. We've worked with the divisional website that's been set up, so that's something that we've really sort of worked hard on. So we've got a dedicated page on our website. So if somebody sort of Googles, I think, eating disorders in this area, we should pop up, and they should be able to find our contact details. Yeah.
Thank you very much.
Okay. There's no other hands. If I could just say thank you to you all, and just to echo Dean's point, I think actually, this is about, obviously with everything we do at Humber, it's about real people and their families, and so you can be completely forgiven for showing compassion, because I think if we lose that side of it, then we just get fatigued, don't we, in terms of these things, and that's not good for staff, and that's not good for the patients and their families. But I think what's really important, we've heard today, is that you're making a difference, and that's really important for everyone in the team. So I thank you for that. I put a question in the chat box. If someone can answer me that at some point, just put it in. I'll pick it up later, just around education support, because I know we do that really well in Inspire, and that's important to these young people as well. But thank you so much. Look forward to hearing more about how it's developing, and thanks for your time this morning.
Thank you.
Great. Okay, then we'll move on then to my report. I'm not going to, obviously I put in my report about what's been happening with NHS England since we last met. Yeah, not to understate it, a lot, and lots of personnel changes, lots of new directions, but in some ways sort of focused as well. And it's picked up in Michelle's report, and I'm sure we'll come on to it in other parts of the agenda. But some big changes happening there. Just to say to our team at Inspire, who were inspected by CQC, they did a fantastic job, I think, and showed how just professional they are and on it in terms of what they're doing and how they're delivering, and confident, and of course all the support from everyone else involved in that, Hilary and everyone else who worked through that process. And it's been so good to see as well. I'm sure we'd feel assured about this as a board, just actually how we are really incorporating in our comms, but there's a lot of work going on with different teams, division by division, on preparedness for a CQC inspection as well. So I just want to say congratulations to everyone on that. Again, I attended an EDI event yesterday at Humber, and again, I just wanted to say thank you to everyone involved in that, and just a particular shout out to a service user, Nathan, who has presented to the senior management team and operational colleagues as well, who has working, and again a shout out, there's lots of people involved with it, but Yvonne Flynn has worked really hard in this space as well, and it was a really great afternoon. It was all about inclusivity, it was all about re-establishing the Patients Forum, which they're trying to work out what a new name might be for that, but it was a good afternoon. I was really pleased to meet some grandmas and other family members who joined on the day as well. So congratulations to everyone on that. Anything else on my report? Everything else in there I think is explained clearly. Anything else anyone wants to pick up? Brilliant. Okay, thank you. Move over to Michelle and your report, please, Michelle.
Thanks, Chair. Good morning, everybody. I'm sure my director colleagues will help and assist as we go through the report, because there is an awful lot happening, and we can only touch the surface in this report, but it is an exceptionally busy time of year, on top of an exceptionally busy time of year all the time. There are 3 policies to ratify at the end of the section: the complaints and feedback policy, the nutrition and hydration, and the antimicrobial stewardship policy. Put my teeth in today. Lots on leadership visibility. All my colleagues have identified where they've been. I've been exceptionally busy going through the organisation, and lots of really good practice, lots of continued good morale across, but lots of challenges as well, mainly through the acuity aspect of our patients, which we have had a lot of conversations about before, the growing acuity. So we've got growing demand in the system, but we've also got growing complexities of cases. And the executive team are spending a bit of time just talking about how we can continue to support staff with what will become the norm, and not just within our inpatient units, but within the community as well. Also great to keep checking into the Proud programme. So I thank Karen and her team for the facilitation of that. It continues to get exceptional reviews, and staff are really enjoying their time on that programme, and it's really great to see the update in the report of the postgraduate scheme, the alumni work that we're doing for when people graduate from that. Staff side, I've put a little bit of from the staff side point of view. I'm sure Karen may want to touch on that, but we have got good relationships with our staff side. Some challenges, which you would imagine, but good working relationships, and it's good to see those appointments in their recent AGM. You will also see in here about a birthday card. It's been something that we've been trying to facilitate for a while, and this is a birthday card that will go out to staff just to say happy birthday to them, and we'll remind them that they do have the allocated extra days leave, which is very unusual. It is not in all organisations. We've obviously looked at the legality aspect just to reassure the board and the GDPI, etc. And there will be an opt-out process if people don't want to receive that. So that will start from the 1st of April. There is a section in here, and thank you to all my non-exec colleagues as well as my exec colleagues, around the reporting groups into committees. We've had a bit of a look at that. One, to look at duplication, how we can streamline them, because we don't want people to go to numerous meetings all the time, and we'll continue to work on officer attendance and staff attendance at those. But you'll see the vast majority of the operational groups will report into the operational groups, including QPAS, which will report into EMT. The Chair, Caroline, has touched on NHSE. Lots happening within NHSE as that starts to merge, well, not merge, but be abolished, but linked into more of the Department of Health and Social Care. And also the changing landscape for integrated care boards with their reduction in staff by 50%. We are waiting for some other planning guidance to come through in relationship to that. Not our traditional planning guidance about operational plans, metrics and money, but how that is going to be facilitated through the system, the reduction in staff. We are reaching out to our colleagues to support them through that difficult process, and I will keep you posted as we get the details of that through. And we'll touch on a little bit later on in the meeting Jim Mackey's new team, because they have been established and announced. Also in the report, there is a MAPA update that Lynn has produced. Thank you. I'm sure Lynn may want to say something about that. It's according to the work plan. And it's Hilary's last report, so I'm sure she'll want to comment on some things that in a fantastic report. The culture of care update is in there, prevent's in there from the Stockport. We did a bit of a review and our prevent guidance, and as the chair's mentioned, the CQC. Lots happening in the People's Directorate. I'll let Karen pick out anything, but just a couple from me. Obviously, we continue to review staff mandatory training. We want to make sure that that's as streamlined as possible. We have now got the passport where staff can passport the training as they come into the organisation from other NHS providers. But also we want to make sure that it is fit for purpose. And as we add things, we have a look and see if we can move things off. So we'll continue to do that. And the flu, yes, we talked about the winter plan yesterday at the exec team. We talk about the flu plan. We just no doubt get into the longer days and the warmer weather, and we start to talk about our plans for the winter, as you would expect. But we are looking at our flu campaign for next year. And then there's lots on the patient and carer race equity framework that we need to be implementing from the 1st of April, and early bird notification of our research conference on the 19th of November. Seats are limited in the auditorium and usually sell out very fast. They are free, but they're usually snapped up, and it will be a hybrid. And then I'd like to take any comments on the comms report, the communications report. It's a new style. What we've tried to do is put the operational work into outputs, but also linked to our strategic goals and objectives. So any comments on that, welcome. And also on the new style Health Stars report. A lot there. I've identified some of the highlights. I'm sure there are others that I have missed, so apologies for that. But as always, I'll pass over to Lynn just to give us a bit of an update on the operational aspects and where we're up to with our OPAL framework, etc. So thank you, Lynn. Thanks, Chair.
Thank you.
Yes, just in summary, thank you. So our Trust OPAL position at the moment is quite stable, but we have a position of OPAL 3 for mental health over recent weeks, and OPAL 2 for our community services. The mental health position is due to rising demand, particularly through the ED. So we've been having a really close look at that. We have a seasonal rise in demand at this time of year, typically anyway, but not usually through ED, specifically the emergency department at Hoft. So we have been looking at that closely. Thankfully, that has stabilised actually over the last few days, which is good. And those have been predominantly for service users not previously known to us as well. So that's been interesting. The system wider pressures have improved somewhat from that very demanding, challenging period through January and early February. So generally those acute hospitals are at the OPAL 3 position, and they do rise into OPAL 4, but for shorter periods of time than they were previously. The whole system has moved on to reporting through the UEC Radar app, which obviously means that it's real-time data. So that was quite a transition for us as an organisation as well. So, and it does mean that there was a review and some changes to the metrics that underpin that reporting process as well. So I just thank all the operational colleagues that have worked hard to get that position in place. I understand we're actually the first system in England that achieved the system-wide implementation of UEC Radar. So focus continues to be specifically on those patients in the acute hospitals that have that no criteria to reside. There's a lot of work still happening, but the figures predominantly are sort of quite stable around that. So still significant focus, and obviously our community services support with that as well. I'm pleased to say that the occupation of our virtual ward has improved quite significantly actually since January, and that's because we've been able to do sort of quite a lot of work with our partners to improve that position as well, and there's been some changes in pathways in North Yorkshire as well. So we are in that position. Michelle's already mentioned the flu. I'm talking about next winter as well, which feels very odd when the sun's shining so nicely outside. But there's system review of last year's 24-25's winter plans taking place right now, as we then take those lessons learnt from this last winter, which was obviously very challenging, into our next year planning right now. So there's no gap in that planning process. So stable position, I guess, overall, but it does really make me sort of think about how we're going to have an impact on next winter that's going to mitigate some of those risks and challenges that we saw last winter as well. But obviously the system is looking at that. So I'm really happy to pick up any questions in relation to that overall position.
Thanks, Lynn. Any other members of the executive management team questions? Hilary.
Thanks, Caroline. I just wanted to point out about the culture of care. I mean, it's all there for you to read. I have brought information before. One of 60 providers in this programme of work, which is a national programme of work, and really positive to hear from the national team that Humber are leading the way with the work that we've done. Just wanted to point out to the board about the 15th of May, when there'll be a full presentation on the work. So obviously, it'd be really good if some board members could come to that as well. It's all been led by Alex Hamlin, who's clinical psychologist. She is coming to the next quality committee, Philip, to give a bit of an update as well. But it'd be really good to get some board members at that celebration event. Closely aligns to our close culture work as well, so we've not lost that link either.
That's great. Laura, if Laura can make sure that board members are sent that date specifically, if they just don't take it up today, that would be really helpful, I think, too. And this is an opportunity also, as this is your final board meeting, Hilary, just to express our thanks to you for your work and your service. It's been absolutely delightful to work with you over the past 3.5 years. So let's, I think, you can show your appreciation either with a virtual hand clap or a real one, whatever rocks your boat. Let's do that.
Thank you.
Thanks so much, Hilary.
Thank you.
Thank you. And I know there'll be other events where people will be able to express their thanks as well, more personally. So thank you for that. Any other members of the executive management team? Kwame.
Yeah, no, thanks, Caroline. I think the work around the culture of work segued into what Michelle did mention on the PCREFT. The full title, which you will be hearing a bit more about, is Patients and Carers Race Equality Framework. This is an important work which is mandated by the NHS. And the principle behind the PCREFT is for organizations to actively become anti-racist and to reduce the racial inequality that happens in mental health services, especially around the use of mental health acts and also restrictive practice. So there has been pilot sites over in different places, and from 2020, this year, April, our organizations are to show within their governance structure that they are going through the principles of PCREFT, and mainly to do co-production, have leadership structure and accountability structure, and also use data and transparency to demonstrate that these practices can be reduced. So we have been working very hard in this organization to make sure that we incorporate that, and there's a lot of work going on within different divisions in the leadership structure to be able to, it's not a pass or fail, it's along the maturity matrix. So we have to show progress that we are working with Afro-Caribbean group, the All Alliance nations, and all kinds of groups to make sure that the principle of PCREFT is embedded in this organization. I think the oversight will be through the mental health legislation group, and I'll be sharing more information at that group. Thank you.
Okay, thank you very much, Kwame. Okay, I can't see any other members of the MT because I know there's other reports on the agenda coming up they're going to speak to, like Pete and others. So any questions to colleagues from the MT or Michelle? Steph?
Yeah, so
just a question on the sexual violence and misconduct update, which is from Karen. Obviously, this area is really important to us as a trust in terms of getting that culture where people feel safe at work and know that they will be supported by the organisation in terms of our approach and policies. I'm just interested to know how this approach will link to our No Excuse for Abuse framework and how that will all fit in and be accessible to staff going forward.
Yeah, it's a really good question, that, Steph. And as we've developed this programme of work, we've made sure that all of the relevant programmes align. So John Duncan is our EDI lead, who's kind of led the way a bit in terms of engaging across the organisation around No Excuse for Abuse, is actually a member of the sexual safety group as well. So we're seeing that alignment and that correlation across all of the programmes of work. And what we also did as well, aside from that, is the Respect campaign has, which is also almost the sister campaign to the No Excuse for Abuse framework, which also has a sexual violence poster and narrative that sits behind it, like I say, so that we can see that alignment across all three. And now it's that work really just to drive the message into the organisation. So we're doing as much promotion as we can, and John is getting as far as and wide as he possibly can, as are Rosie and Alison as part of their role as co-chairs of the sexual safety group. Okay, thanks. Is that all right, Steph? Great, okay. Any other questions on the Chief Exec's report? Okay, all right, thank you. Good. Can I just add, I just was really pleased to see that, and I think it's under your section, Hilary, that the coroners have approached us for some support with psychologists in terms of, obviously there's a lot of very traumatic issues that they're exposed to, and that's it. We know that for our own staff, and we give our own staff support. I think it was a really good example of partnership, and I was really pleased to see that in the report. Thank you. Okay. Moving on then to, let's do our voting on all of this. So the reporting group's proposal, is the board happy to approve that proposal? Yep, great, thank you. And we have ratification of policies for complaints and feedback policy. Happy with that to ratify, thank you very much. Nutrition and hydration policy, happy to ratify. Antimicrobial, oh gosh, I'm not going to be able to say antimicrobial, that's right, isn't it? Sort of stewardship policy. Are we happy to is there a doctor in the house? Are we happy to approve that? Thank you very much. Okay, right. Thank you. Okay, we'll move on then to publications and highlights report.
Thanks, Chair. Again, I'll keep this very short. I'll take it that people have read the report. Highlights, obviously, some of the major documents that have come in, the relative executive director lead, and a little bit about how we're linking that into our current plans and work. So I'll just take it for comment or questions, Chair.
Thank you. And it's a really good report, really helpful. Any questions? Great. And at your leisure, you can go on all the links. It's really informative. Thank you for that. And we move on to publication, patient-led, assessment of the care environment. Pete.
Thanks, Caroline. So I'll try and be brief. So PLACE results came out on the 20th of February, and as a trust, we completed an assessment of all our inpatient estates. In terms of the published results, they're included within the report, and as a trust, we generally compare well with the national average in previous year's performance, but I do think there's probably two areas where they're pulling out from the report. And the first of those is organisational food, where we have seen our score improve from 85% to 95%, which is a really significant improvement for us because food has often been a challenge. And a lot of that is down to the work we've done on electronic food ordering system. So a big thank you to the facilities management team for that work being pushed out. And I think we did mention it in the CEO report. We actually are the 4th trust nationally for food scores. So again, that's something we should really celebrate. And then the other area I think is where we're pulling out is disability scores, where again, we've seen a marked improvement from 80 to 95%. And that again relates to some of the work with the facilities management team, where we've done accessibility audits and accessibility plans, if I can get my teeth in, for all our estate. And we have plans in place to address that. And finally, as we have done in previous years, we have resource set aside in our capital programme to address any issues we've identified in our PLACE survey. So we continue to strive to make improvements wherever we can. I'll stop there, Caroline. I'm happy to take any questions.
I'm glad it's not me just tumbling over my words. The solidarity with me on that one, Pete. Thank you. Any questions to Pete? No. Pete, can I just ask that in future reports? I mean, I know Katie Coleraine from the Board Support Unit on my behalf has been liaising with Jane about in the next round of visits that we'll have some governor representation on those teams, which I think is a really good structured way for them to be involved. I think it used to happen. I think we're going to re-energise that, and Michelle and I have talked about that. So thanks to Jane for working with us on that.
Lovely, thank you.
Okay. Moving on then to the Health and Inequalities Plan. Sarah, good to see you.
Thanks, Caroline. So I'll just give a brief introduction to the plan. I'll take it as read, but I'll just pull out a few key points. So the plan's being presented today evolved from the previous delivery programme and from really extensive discussions with clinicians, corporate and operational teams and wider engagement. We're already starting to discuss how the plan will be operationalised, and that'll be through a combination of focused working groups and discrete projects, where there are discrete projects, and then alignment with divisional service plans and quality improvement plans. What's happening when I've been talking to some of the divisions about the ideas we've got in this plan is there's quite strong resonance with the divisional and corporate priorities, including, for example, a new comms plan supporting health inequalities and trauma-informed agenda. The plan's really focused on what we're actually going to change. So you'll notice there's a what we will do section against each of the goals. And we've included a delivery timescale to provide some assurance about the deliverability of the plan. Taking on board comments in previous board sessions, we've also included a description of how we'll measure impact. And this is through a combination of trust level metrics, such as accessing the DNA data, as well as measuring the impact of service level changes. You know, for example, where there's a QI project that's got measures against that. Although the quantitative measures are really important, the insights we gather from engagement, co-production and evaluation with staff, service users, patients and our communities are, we think, the most valuable evidence of the difference that we're making to the communities we support. As I've described in the paper, the plan does align with this year's planning guidance and the expected direction of travel in the National 10-Year Health Plan. It had been mentioned at a previous board session that we should consider whether we delay publishing this plan until after the 10-year health plan is published. It's currently expected in May, and with the recent NHC announcements, I'm concerned that might be delayed slightly. So I would prefer us to go ahead with our plan if the board is okay with that.
Thank you very much, Sarah. Any questions to Sarah on the plan or comments? No? Oh, sorry, Steph.
Thank you, and thank you for the report. It's a really, thankfully, a really easy read, and really easy to understand. I just wanted to just sort of get a heads up, really, and just get a little bit of understanding of which health inequalities we're going to prioritise in terms of our efforts and energy as an organisation, and who our key partners are in those prioritised areas.
I think it's. I'll try and sort of frame this answer. What we haven't started from doing is saying what are the biggest inequalities within our services. Within some services, we are looking specifically at what those major inequalities might be. To some extent, that's driven by the national reporting requirements. So we have to do some reporting on access to talking therapies and to CAMS by deprivation decile and ethnicity. Unfortunately, we do have decent data in those areas, so that is driving some focus on those. But we also have quite a lot of initiatives within the plan that kind of focus on how we improve accessibility to our services across the board, such as making sure that we're implementing reasonable adjustments properly, so that it's less about focusing on one particular population and more about sort of getting that access right across the board. In terms of working with partners, I think the partners across the ICB are really key to this, particularly working with the ICB on inclusion health. They're producing a new inclusion health plan and working very closely with Place So public health teams with their knowledge of their communities and the areas of focus are really key to this, as well as the voluntary sector with that deeper insight.
Okay, Keith.
Yeah, thank you, Sarah. Excuse me, sorry. Thank you, Sarah. Really interesting report. I had a question around funding, and obviously, you know, how we fund the work that you talk about in there now, and whether with the 10-year plan and it being, you know, prevention being one of the kind of 3 left shifts, whether we'll need to find more funding in the future to do more of that, and how we go about that.
I think a lot of the activity that's in the plan it doesn't require additional funding. Some very small scale bits of additional funding, like we're looking at a comms campaign around some areas of health inequalities, but that's already been agreed. I think in terms of the shift to prioritisation, I think that's quite strongly a conversation with commissioners, us influencing that, recognising the opportunities for more prevention within our services, and then taking that back into the system.
Shall I pick up a bit of that as well? So thanks, Sarah. I mean, yes, obviously we need to be realistic. There isn't a heap of cash in the system. I think it's a really good point. Obviously the access to health inequalities money will be very limited. So it will come down to the executive team working within our current budgetary profiles and just saying what we need to reallocate or move around the system, and how that links into some of our other key challenges, such as children and young people, neurodiversity, etc. So I think it's a bit about just being as flexible and as innovative with the money that we've got as we can do, but also demonstrating that we are working through the health inequalities piece. So basically it's from the same pot, but we just might need to move it around the system a little bit, our own internal system. That makes sense. Thanks.
Okay. Phil.
Sarah, thank you for the report. Really interesting. Yeah, I'm not. Well, we've got to keep a focus on what we've got to do, but this should be core to what we are as a mental health trust. All mental health inputs are within that context of who the person is, and are we training our staff adequately to read who's in front of them, and also how to make their interaction as meaningful and as understandable as possible? Because I think those are the things that we can embed into how we work.
Absolutely, really strongly agree with that. There's some very strong alignment with some other programmes of work that are going on across the organisation. So we've got our trauma-informed approach, we've got the work and culture of care, which has already been mentioned, and both of those have training and dissemination of good practice associated with them. We've done quite a lot of training on health inequalities itself. But it's also aligned with some work that we've been doing around assessment and formulation, moving to person-centred care. So it really draws on a lot of themes that are focused on the how we make sure that health inequalities, that trauma-informed, that being person-centred is at the heart of delivering care. And I am working with divisions and working with the clinical leads to identify how that's being implemented within each of the divisions.
Thank you, Sarah.
Kwame.
No, just to add to that, I think that the training and support for staff in the front end to be able to appreciate health inequality and how they can support to improve health inequality of our population is what is a key to this. So it becomes almost like at some point, hopefully it becomes the treatment as usual, where everybody is aware of. And we've already started putting that into practice in terms of our policies. So our impact assessment includes things like digital poverty, includes things like illiteracy, includes things like race. So all those things are going to be in the front end to be able to support health inequality, not just a project in isolation from the front end. Thank you.
Okay. I mean, I presume linked to that is understanding the data about the population's telling us, because it could be white working class men from an industrial background, manual working background in parts of our patch, which I think is probably the case. I think the ICB material confirms that. who actually are furthest away from some of the health services that they actually need. So, I mean, you have, I think this plan is where we're going forward is in the right direction, but presumably want that more detailed texture on it, so people don't make assumptions about who they think is furthest away from health, which might not be the case, but actually who is really at risk. And that data dynamic and analysis is going to be really, it seems to be really important to this work. Is that fair, Sarah?
I think it is, and some of the work we did on talking therapies DNA rates, for example, didn't actually identify that it was the most deprived communities who had the highest levels of DNA. It was actually the more affluent communities. So yeah, very true. We don't want to make assumptions that the national trends are necessarily applying to our data.
Okay, thanks very much. Okay, first of all, we are approving this document, but can I just get a sort of nods of agreement with Sarah's other proposal today, which is not to wait necessarily for, you know, everything with the 10-year plan, but to carry on with the work in this area, which I think is a practical, common sense idea. Is everyone happy with that? Great. And is everyone happy to approve the document and the plan? Thanks so much. Thanks, Sarah. Thanks very much indeed.
Thanks, Sarah.
And now we have Paul for item number 11. Is Paul with us? Sorry to have kept you waiting, Paul.
That's fine, no problem, Caroline. Thank you. Morning, everybody. As you will see, the
oh, you've gone on mute, Paul.
I don't know what happened there. I don't know where I got to when that happened.
It wasn't me. I wasn't muting you.
I'm sure. Yeah. So the report outlines the recommendations made out of the independent investigation report into the Nottinghamshire incident. As you'll see from the report, out of that came 12 recommendations that we've been asked by NHSE, that all providers and ICBs review themselves against these recommendations. So from the report, our initial response to this was to review where we think we are and where we think these recommendations and how we as a trust have got things in place. As you'll see from page 6, we've tried to put a table in there so that you can see that there are some areas where we can show some really good assurance. We've identified areas where we might need to do a little bit of work and somewhere new actions might need to be taken. What our intention is that although that initial review was needed to be done timely, what we want to do is make sure that we do this with all of our stakeholders, with all of our partners involved, and really importantly our service users, to come up with appropriate actions to go on our existing action plan that we've already got from the CQC, from the outcome of the CQC inquiry, so that we've got all of the actions in one place. Our intentions then will be to come back to through the appropriate governance mechanisms that we've got through our executive management team, through the quality committee and to board, to outline the action plan, which will then be provided up to the ICB and NHS England by the 30th of June. Happy to take any questions.
Thanks, Paul. Very clear report. Any questions from board or comments? No, thank you. Thanks for these reports. I know you've come back several times, Paul. It's really helpful to be kept in touch. I know there's other areas of governance and assurance you're reporting into as well. So appreciate all the work being done by the team.
Thank you. I will pass that on, and it is really important that we keep this onto this to the highest possible agendas, like the trust board, and we'll be continuing to have these conversations as we go on and report the progress that we're making. So
thanks very much. Michelle.
Yeah, no, I was just going to reiterate what Paul said. Actually, I think it's really good work, and we just really need to constantly, from the board position, just keep checking in, really, both with the national picture, but also with our local picture as well. So thanks, Paul. It's a really good piece of work, and I know the quality committee will continue to oversee it. But I would like that, yourself and the quality committee just to keep bringing us that assurance that we are working through. We are working through it. It is a complicated area, but thank you.
Thank you.
Thanks. Cheers, Paul. Have a good week.
Thank you.
Okay, we'll move on then to item number 12. Pete.
Thanks, Caroline. So this is just an update or a position statement on where we are against the operational planning priorities that came out in the National Planning Guidance. Paper follows and supports what we've done at operational service planning and divisional service plans, and also reflects the current system, our current position with the system on the wider ICS plan. We saw an early version of this, didn't we, at the February strategic board, and we've updated it and nudged it along, and it follows the format we agreed with the board last year. I think, happy to move to questions or if any of my colleagues want to add anything, but I think the next steps would be to use this information to complement the board assurance framework going forward and weave it into that. So I'll stop there. It is what it is, but happy to take any questions.
Thank you very much. First question from Phil.
Yeah, thanks, Pete, for this. Just around sort of GP access, the sort of proposed solutions, just last year's primary care network DES, I think we should be thinking about doing some other things. It even says new telephone systems, well, they're last year's news. So I really think we should just think about putting some stuff in that's what we're doing this year and what the practices are doing. And then the other way around, sort of the planning guidance to increase patients that are having the blood pressure treated to NICE guidance or cholesterol, it's all down for primary care, but surely the core mental health services, particularly with things like learning disability health checks, that contributes to that as well. And I think if we're really interested in reducing health inequalities, we also need to think that mental health trust core provision has some input into our patients' physical health as well. So I think it'd be good to maybe to think about how we can reflect that.
Thanks, Philip.
Okay, Steph.
Yeah, thanks for the report, Pete. It's a couple of areas of query. One is the reduced time people wait for elective care, which is in relation to community. The section on positive assurance just seems a little bit out of date, maybe, and needs bringing up to date. But I have a question around that, which is we've got, if we've got 278 patients waiting more than 18 weeks for community intervention, which I think is largely physiotherapy. What is the reason for that, and what plans do we have to get that down? Is it a staffing issue? Have we not got the right staff in place, or is it the way that we're doing the service? Just want to understand that a little bit more. And in relation to A&E weights, obviously, which is not directly our responsibility, I'm wondering if we've got any figures on how our service in relation to mental health within A&E is having impact on A&E weights. So is the positive stuff around improving people's wait times in A&E and what impact that service is having.
I think Lynn will be good at both of those, to be honest, because I think the ED streaming is getting some real national recognition, to be honest, Steph, and I think it's a really good question, as is the other one, but I'll pass it. Sorry, Lynn's got a hand up now. I'll pass it over to Lynn.
Lynn.
Thank you. Yes, I'll pick up both your points, Steph. On MSK waiting times, it's almost entirely due to increased demand outstripping our resources. For that, it's not related to staffing shortfalls predominantly. Now, we constantly look at the service, as you would expect us to, Steph, and the model that we're working to. We've applied our capacity and demand analysis work repetitively to this area as well. It is a focus right now. So again, we are looking at what more we can do with the skill mix, the clinical model, to alleviate, to reduce those over 18-week wait times. Obviously, it's a conversation that we're having with our place colleagues and commissioners as well around that position, but it is rising demand that underlies the increase in waiting times. In terms of ED and our responsiveness around mental health presentations, we have a mental health liaison service, as you're aware, placed in the ED. We have a KPI that for every referral that the team receives from ED, they need to respond within 1 hour. And actually we achieve that target consistently as well. By doing that, obviously we're in a good position to avoid any breaches in terms of the 4-hour wait time. There are exceptional ones from time to time, and they are almost entirely when cases are very complicated and a number of agencies are needed to respond. Every time that occurs, we review those and identify the lessons learned. But because of the effectiveness, as Michelle says, the fact that we now have that streaming service, which is getting national recognition in terms of that place that's much better equipped, it's a good environment away from the busy ED, you know, from a service user's point of view, and the positive feedback we get from patients and families is great around that. But obviously that supports us phenomenally to avoid any unnecessary breaches of wait times in ED as well.
Thanks, Lynn. Chair, I wonder if I could just come back on that.
Yeah,
I mean,
sure.
the emergency department service, I'm just wondering to what extent we've been able to share that across the system, because, you know, the national recognition is brilliant and quite rightly so, but we've got opportunity surely to roll that out across the system within other trust areas. And on the MSK stuff, I'm assuming that the grip on that is, in terms of governance, is via the quality committee. Is that right?
It is ultimately via the quality committee staff, yes, and the quality committee do receive those quarterly, highly detailed waiting times reports to sort of give that a description of what we're doing to address all of our over 18-week waits.
Brilliant.
I don't know if Phil wants to comment.
Phil? You're on mute, Phil.
Not really got anything to add, Caroline.
Okay, fair enough. All right then. Could I just ask a question on the one about increased number of children and young people accessing services? We give 3 examples in the box, which I think are all really solid. Have we got any sort of firmer data about, you know, indicating numbers increasing from our inputs into this area? Because obviously there's a national one of 345,000 more young people. I just wondered, I mean, how we are, I suppose, measuring the outcomes of these various really good projects that have been delivered, and can't we feed that back?
We do include it in the long-term plan dashboard, don't we? Okay. Children and young people contacts, Caroline. I can't get to the page quick enough to tell you, but it is on an upward trajectory. Okay.
It's just that some of the other boxes have some more numbers in it, and I just thought if they're even just to say it's on an upward trajectory, the numbers of young people, our services, just a thought. I know it's probably detailed elsewhere, but it's our message, isn't it? I suppose.
Absolutely. Thank you.
Brilliant. Okay, thank you very much. I can't see anybody else's hands up, so thanks for that, and thanks for the questions. Very helpful. Thanks, Pete. We'll move on then to item number 13. We've got Alison with us as well. Welcome.
Morning, everyone. Morning. Michelle, did you want to start, or do you want me to?
No, I think you can just launch into it, Alison. Good morning. Obviously, it's just an update on the. Well, just an update. It's an important update on the collaborative. So over to you, Sarah.
Thanks. Morning, and morning, Sarah. Nice to see you again. It's been a while, hasn't it? So just to pick out the key priorities, really, and the key headlines from the paper. There's a lot of work happening in relation to developing the future mental health, learning disability, and autism collaborative, and that moved to our transitional state. The strategy, the draft strategy and core offer, there's been a lot of engagement and consultation on that, and we've recently been having meetings with the DCSs and the DASs in the local authorities, so we're hoping that we'll get a final strategy over the next couple of weeks, and then an update on where we are with operational planning for 25-26. An update on the work that's been happening in relation to the scoping for autism and ADHD assessments. Still got further work to do, significant work to do in that area. And we've recently submitted capital bids. There's some capital funding available. I've recently submitted some capital bids to NHS England from a Humber perspective. That's for the psychiatric intensive care unit, PQ, and Inspire at CAMS. So we'll await the outcome of that. Everything has been submitted. The work on the National Inpatient Transformation Programme continues. The focus there is on developing and building relationships with the independent sector and the market management, looking at development of our PQ services and how we can work collectively across Humber and North Yorkshire on that, and a real focus, continued focus really on reducing the number of people who are sent out of area, particularly in relation to older adults and rehab services. And then the final piece of the report just shows an update on where we are with performance against trajectories as we're moving into the very near the year end, and now our thoughts are turning to the future plans for next year. So just some headlines there. I'm happy to take questions and comments. Thank you.
Thank you, Alison. Any questions or comments? Okay, thank you for that update, Alison. Have a good rest of the week.
Thank you.
Oh, sorry, Phil. Sorry, missed that. Sorry, thanks, Michelle. Phil, sorry.
Sorry, Caroline. I'm a bit slow on the technology this morning because I'm on an iPad in a hotel room. So it's not,
I don't want to know anymore.
it's not yeah. I would just, from my understanding, because out of area placement is such an important topic, is that how will the capital that informs reconfiguring the PQ estate and the CAMS inpatient and the 12-bedded Navigo unit, how does that actually work at reducing out of area placements? I think I just need to know a little bit more.
I mean, I'll start, and then Lynn may want to pick up from a Humber perspective as well. So in relation to PQ, what we're looking at is how we can have a PQ that serves right across Humber and North Yorkshire, because we've got a number of people from going out of area. So if we're able to reconfigure what we've currently got, that will enable us to reduce the number of people going out of area. And it's similar with the older adults and the rehab that the bid that Navigo has submitted. Lynn, is there anything you want to add to that?
I guess it's just to give Phil the assurance that this is underpinned, Phil, by obviously really close examination of our demand across Humber and North Yorkshire. So we've done the usual sort of calculations that you would expect us to do. What capacity actually are we missing, whether that's male beds, female beds, taking into account the demand across, Navigo, for example, don't have their own PICU, but they do generate some demand. So all of that has been taken into consideration. So we know, therefore, sort of what the bed configuration should be going forward. We've also taken into account as well that some of the out of area placements are due to mixed gender sort of safeguarding concerns as well. So a single gender provision is part of the proposal here, because that alone will reduce a number of out of area placements as well. So Humber obviously do have the biggest demand. We have the biggest provision already. So we've absolutely been integral to this work.
Thanks, Lynn. I think that's the assurance that I was seeking, really, to understand what that meant, really. Yeah.
Okay, thanks very much. Thanks very much, Alison.
Thanks, everyone. Bye. Have a good day.
Thanks, Alison.
Thanks, Alison. Take care. So we're going to have a break, but just to say, for anybody watching our board meeting today, you may have noticed that some of us have got a backdrop with Ramadan Mubarak on it, and some of us haven't. So I think I should just explain that it is a glitch in the system. I aspire to a time when AI will automatically update for an organisation the backdrops of everybody. So I no longer have to worry about this and things going wrong. So if someone can work out the AI on that, I think we'd all be very, very grateful. But just to say to all our staff of the Muslim faith who may be fasting this last month, and to any of our service users and their families who are also doing likewise, or anybody watching our board meeting today, Ramadan Mubarak, and I know it's, I think, ending on Sunday, where I think after that there will be some feasting going on, but I hope for our staff in particular and any of our service users and our inpatients of Muslim faith, we've been able to support you during this period of fasting. So I hope that's gone well. Okay, thank you. Let's have a 5-minute break. It is 10:56. Let's just come back around, you know, I don't know, 11:01 or thereabout. We'll restart. Thank you. 5 minutes. Okay. Okay, let's carry on with the board meeting after that comfort break, and we hand over to Karen on item 14, the National Staff Survey results.
Thank you very much. And so, yeah, I'm really pleased to present today formally at our board this year's staff survey results. And these are following the publication on Thursday, the 13th of March. So prior to that date, the results were embargoed, and we did have some teasers along the way with some reports, but this is the formalised position for our organisation. And I think largely what I'll do is pull out some headlines and then go to questions. So compared to 2023, where we saw quite a big leap across many of the areas, 2024, I think we would describe as a bit of a consolidation year, and that is no bad thing. And actually, when we look at our comparative scores, actually maintaining and improving, whether that be marginally or otherwise, is actually really positive, given the extent of some of the declines at some of our maybe neighbouring trusts and across the NHS. So what I'm pleased to say is that we've actually improved across our own scores in the People Promise themes compared to 2023, and that's across all of those 9 areas. We're also reporting a better position than the national average and also compared to our benchmark group. So again, a really positive position in terms of maintaining that position where we're incrementally improving year on year. Underneath each of those People Promise themes are a number of sub-themes, so they're all broken down so that we can then start to understand some of the experience of our staff in other sort of more aggregated areas, as it were. And again, we're really improving across benchmark group average scores and national averages, where we report stronger position across all of those sub-themes. That said, there are a couple of areas compared to our own scores in 2023 where we have deteriorated, but that is statistically insignificant in terms of those deteriorations, but are picked up nonetheless within the area of focus section of the report later down. Picking up on the 5 core questions, so obviously the questions that nationally are looked at and we look at in terms of not only staff experience but patient experience, again a really solid position. For the question regarding recommending the trust as a place to work, we've seen an increase from 49% in 2019 and that's gone up to 69% in 2024, and that was actually a 3% improvement on last year's scores. So again, that's really positive and something that we always keep an eye on at this organisation. That said, always things that we can do, but actually we're seeing a really solid improving position in that particular domain. We're also seeing positive improvements across the other core questions, with the exception of question 6A, which is I feel my role makes a difference to service users. We have seen a marginal deterioration in that position. So as I say, when we reflect on section 6 of the report and those areas of focus, that is something that the executive team have noted from this report already and something we really will be focusing on in the year ahead. But that said, care of the organisation care of patients being the organisation's priority and recommending the organisation as a place for treatment have gone up as well, and we compare really favourably compared to the national scores and our benchmark group as well. So actually there's an awful lot to celebrate within this survey. Moving us down then to the key areas of focus, we do have a discussion in our executive team pending in terms of what that looks like for us. So we have pulled those areas out question by question in section 6. However, some of we've got kind of 4 areas that we're in discussion about in terms of that real area of focus that we take forward in the organisation. So I'll draw those out. So question 6A, something we really want to focus on, as I've just mentioned, my role making a difference to patients and service users. There is a discussion ongoing at the moment around the health and wellbeing question, particularly relating to stress and psychological support. We're having an active conversation with our health and wellbeing group at the moment about what that looks like and how we can enhance that package. And what I will say is that People Promise theme area around health and wellbeing was one of our best performing theme areas and saw significant improvements. But when you drive down into question level, stress and psychological support is coming out as something that our staff do need us to look at. And then the question around equality and diversity and inclusion, and ensuring that the experience of those in our workplace who are from an underrepresented group have an equal and solid experience when they're in the workplace. That's something we have been on a journey with through our various campaigns, but again, something that we do need to continue that work on, because again, that is a national statistic, unfortunately, but it does demonstrate to us that, again, it needs some area of focus. In terms of the next steps around the reports, so we do have IQVIA, our administrator, coming to the next board to deliver the report fully in a presentation form. We're also disseminating all of these results out into the divisions and directorates, so everyone will grapple with what their results say and mean to them, and they'll be working within their teams and their service areas to develop their bespoke actions. And like I say, within the executive team, we'll be looking at those core areas of organisational focus that we really do start to drive some actions under over the forthcoming year. So I will leave it there and I will open it for any questions.
Thank you very much, Karen. A lot in there to be really pleased about, and a few other things that obviously you've identified that need unpicking more. Over to colleagues, questions, comments. Michelle?
Yeah, I just want to say thank you to all the team, really, because I think what's really important is for the board to know where we came from, because we were propping up the rest of the rest, and I mean all NHS organisations, and not by a short margin either. So yes, we need to continue to work on the response, even though it was high benchmarked. We need it higher, and we do need to have a bit more of a look at some of those other scores as well. But I think it's a real team effort, and I want to thank all the execs, but also everybody in the organisation as well. And it's a really helpful document to look at, that not just our strategy, but things like recruitment, the health and wellbeing strategies that we're doing. So I think it's good, but we never sit back on our laurels. So the exec team, we've always looked at those areas that we're out by 0.1 or by 0.2, I can assure you on that. And we have shared it with staff, and we're getting some positive feedback back, because sometimes it's always best just to stress test it with staff and say, look, this is what we've got, how does it, and then they're saying, well, actually, yes, that's roughly what we think. So I think that's positive as well. But I commend it for questions, but just wanted to say thank you to everybody, and it is a team effort.
Thanks, Michelle. Dean?
Yeah, likewise, it's we've discussed this at the People Committee as well, and sort of interrogated the data, and will continue to do so on action plans through the year. But it is a pleasing report, isn't it? But without being complacent, which I think is right. And as Michelle said, really, this is a really good indicator of sort of culture change over a period of time. And it's important because we know staff that are engaged in their work provide better patient care. So it's not just good in its own right in terms of a measure of how well staff feel at work, but we know that that really impacts upon patient care. So we're always curious, I think, about what we can learn, what we can do better. And I know Karen and team are working on those action plans and looking at the work that goes on in directorates. And then the other information we'll have access to at a later date will be the free text comments that'll come through, and I know that those will be presented in a sort of thematic way. What is it that staff wanted to tell us that they couldn't answer, a score on a question to. But just echoing Michelle and Karen, really very pleasing and good to see the work continuing.
Thanks very much, Dean. Priyanka?
Thank you, Karen, for the report, and it's very encouraging to see. Just one question, I noticed that you said that you were looking at psychological support for staff, and which is very good. And I was just wondering whether there was something that you could do. It might take some time to get things move, the ball rolling, but is there anything that you can sort of do like as a quick fix that people can get help when psychological help when they need?
So I'm happy to jump back in there if that's okay.
Yes,
and So whilst we don't have a formalised sort of package, whether that's Schwartz round or trim training or anything like that, we're looking at specifically at the moment around post-incident support, because we know with the high acuity of some of our patients that is something that's required. But we do have an internal in-house occupational health team that operates as an MDT. We have an OT in there. We have somebody that provides emotional wellbeing MOTs, and we have access to a number of counsellors as well. So it's not that we don't have a psychological support offer. It's just about looking at some of the trends in the organisation and actually adapting that offer to to ensuring that it's meeting those emerging needs that often do. So there is access. I want to reassure you on that front.
Thank you very much.
Okay, thank you, Rose. I've got a question, if I may. So when I was reading through the report, and I'm glad obviously you flagged it, Karen, about the question about I feel my role makes a difference to patients and service users, which had gone down and is below the national and regional average. When I read that, I had a different take on it, without negating what you've said, which is, and it goes back to something Stuart has said at board on a number of occasions, is actually that thing around culturally, do we have enough conversations, where people are working about outcomes and productivity? And use the language so that people can say, what they're doing is actually really making a difference. And that's whether it's clinical, non-clinical. I'm just thinking about, for example, a recent piece of national research looking at admin errors in the NHS and how important that is. So you can apply this in different ways that, enables, if you're not having those conversations, it's all about, we're in work, what have we got to do today? If you're not having the conversations about, well, what has been the outcome? Where have we got improvements? Where we're making a difference? It seems to me it's easy for someone, particularly in the work that we know our staff are involved in, which is incredibly intense and often emotionally draining, that you just feel that they can't express that, or someone isn't enabling them to see that context of what they're doing. Again, when we talked about the Being Humber refresh, to think about down the road how we might culturally encourage more, not necessarily using the word productivity, but really about what difference are you making, and those outcomes as much more part of an everyday thing rather than a report at the end of 6 months on what's happening. I just wonder whether that's, because that's how, when I read it, I think there's a lot of people who do a lot of work, it's really hard, but sometimes they can't see the wood for the trees, that what they're doing is actually how it's contributing to their unit, but how it's contributing to the whole. And the reports that get produced, to be honest, are sometimes beyond people's capacity to absorb and take in as something in terms of how they do their work every day. I hope that sort of makes sense. I just think there's some things there we could do to encourage that and let people see that and identify like that, because I think it's happening. I'm not sure we're really landing it with people so they feel really confident about that. I hope that makes sense. Hilary.
Makes absolute sense, Caroline, and certainly EMT had already discussed that very point about how we have those conversations with staff. I'll let Karen come in a moment, but one of the things we did say was every year we do review the appraisal document, and whether or not we have something very focused in there to make sure exactly that conversation goes on with every member of our staff, because obviously appraisals are for everyone. That's a way we can reach every member of staff to have that conversation. So I know we discussed that, but I'll hand over to Karen.
Karen.
Thanks, Hilary. I was going to make that point, and like I say, that was something almost in many respects that was a bit of a quick win for us, because we know actually I think the access to appraisals and delivering them is probably one of the best performing responses in the country, actually. So we know that we've got active participation in that, so it's a really good platform for those types of things. And aside from that, and in previous years when we've mulled over this particular question as well, we've looked at how corporate staff are potentially responding to this question as well. And I think you're absolutely right, Caroline. We need to draw those parallels between, how we're communicating and the narrative that we use and how we demonstrate to people and get them to really consider their impact on patient care and how how they make a difference to it. So I think you're absolutely right. There's nothing off the table in terms of how we try to tackle this. It's just, like I say, ensuring that we can get the appropriate messaging. And there's something about the soft intelligence and the anecdotal information that we can get that backs some of this up. Going back to Dean's previous point, we're still awaiting the free text themes, and sometimes that's really rich when it comes to understanding some of the backdrop around some of this. So yeah, we'll absolutely take that forward. Thank you.
Brilliant. Thank you for that. Thank you for that response. No other hands are up. I know we'll be coming back to this in different forms in the future, but thanks very much, and thanks to echo Michelle's point to everyone who's been working on this, and to every member of staff who completed the survey. Thank you so much. Okay, let's move on to the Associate Hospital Management appointments and reappointments. Kwame?
Yeah, thank you. So this is to ask the board to approve the appointment of 4 new associate hospital managers and reappointment of 1 associate hospital managers. This appointment is consistent with the Mental Health Act, which asks the trust board to delegate the power to discharge to individuals who are called associate hospital managers. So we want 3-year extension for Jen Hardeman, and then we have 4 new associate hospital managers, Martha Brown, Leah Elia, and Maureen Graham, as well as Alison Cotto. If this is not on the paper, but that will bring our numbers to 16, which has a good mixture of age group, minority population, and that means that we'll be able to discharge our duties of the hospital managers without delay for patients who need that kind of approach. Thank you.
Okay, thank you very much. It would be good to see a sort of, without names, a breakdown of the diversity as a total to know clearly what these additions actually have meant. So we see that assurance, I suppose, in something like that. Maybe that could be circulated to everyone to see what is the diversity composition of the associate hospital manager, include that in future reports. Thanks, Kwame. Is everyone happy to approve Martha, Leon and Maureen and Alison as new associate hospital managers? Oh, Michelle, yes, they are. Michelle, did you want to add something?
Yeah, I do. Nothing about the approval, but just to add to your point, Caroline, I think it's really important that we don't circulate it on the board. And I would just ask Steph really if, I mean, it's not technically, well, it is mental health legislation. If the mental health legislation could get the assurance around the diversity of the hospital managers and maybe feed that in as well, so we could not only see it, because it's something that the exec team speak a lot about. But I think for that assurance process, it might be useful just to sit in mental health legislation committee, Caroline.
Oh no, I totally 100% agree with that. I'm not talking about this being actively reported to the board. I would have liked to see it in this paper, a little breakdown, because it cites diversity, but it doesn't provide the backup. But I think absolutely, I think for Steph, it's appropriate to go there.
Yeah, I would do that. I have the breakdown in film and a small autobiography of the individual, but I wasn't sure whether it was appropriate for the board. But I'll discuss that in the mental health.
Well, it can be anonymised. It's just numbers, isn't it?
Yeah.
You know. Okay. Brilliant. Steph's got a thumbs up. That's good. Great. So happy to approve Martha, Leon, Maureen, and Alison. Yes. And if they're looking in or watch this later, welcome. We value your contribution and stepping up to do this role. Appreciate it. Thank you. Okay, moving on then to item 16. Lynn, I think this is you for an update on EPR, which seems to be going really well, and lots of learning from it. I hope that wasn't a nervous laugh there, Lynn. Okay, right, over to you.
No, thank you, Caroline. Yes, this is the summary paper. Now we've completed the final big phase of the go live from the change of our electronic patient record from Lorenzo to System 1. So I am pleased to say, as the board are aware, that we succeeded with our last final phase. our mental health division. We always knew that was probably going to be the most complicated phase just because of the number of services, the number of staff and the number of service users. And actually it's the flow of patients between services at high volumes in this division as well. So hopefully the paper sort of demonstrates that we were successful and we carried out a robust lesson learned process between each of the phases as well. So by the time we reached the rollout to our mental health division in February this year, we had been able to take all of that learning on board and apply that to the final phase. We were successful, I think, particularly around achieving really good training levels. It does certainly historically EPR systems elsewhere in other organisations, success and failure has been predicated at least a little bit on that sort of training and achieving a really good compliance. So we were well over 90% across the board in all of our divisions. So again, I thank our staff for doing this sort of through the latter phases of winter as well. But I think we overcame that as a challenge, which was good. We've also been able now to roll out and to use the EPR extension, which is the archive solution, so that staff can actually retrieve when they need to anything from historic records on Lorenzo. So that's been successful as well. There is a summary of the lessons learnt in the report. There is a very detailed summary as well behind this that we've taken into account as the programme has continued. We have had very good clinical and operational, but Kwame has led the clinical oversight group that's really supported this programme of work. Again, I think that has been one of our success factors as well. And we're not going to stop with that as well. Obviously, our next phase of work, as the paper describes, is around that stabilisation, optimisation as well. I think ongoing clinical engagement is going to be absolutely key to that. So we know that we've got further work to do for any staff hearing this conversation today. We have got a couple of issues, particularly around managing tasks in System 1 on the mental health modules. We're doing some work. Staff are being patient around that, but I wouldn't be surprised if board members out and about in services in mental health particularly hear a bit about that as well. So just to reassure staff, that's a high priority for us to take forward right now as well. But obviously we've talked a little bit about that sort of productivity, adding value to our service users as well as to our staff and their sort of day-to-day experience at work. Generally, the feedback continues to be very positive still compared to the old system. System 1 is much more favourable. People like how its utility as well. But obviously we do want to make sure we don't stop here. We continue to optimise that and achieve all the benefits that we set out in our original business case. So I'll pause there, Carol. I'm very happy to pick up any questions.
Thanks very much, Lynn. I can see Priyanka.
Yes, thank you very much for that update, Lynn. I saw an email coming through that you and talking about productivity, that you are trying to amalgamate another program where you can sort of, instead of typing everything, you can have like a verbal, you can talk into, and that you're going to. So I think that that was a very good idea, and I thought it would increase our productivity, and very well done on that. That's what I wanted to comment on. Thank you.
Thank you.
Thank you. Thanks very much, Priyanka. I think there are two others, Lynn. I heard at a meeting of the Humber North Yorkshire ICB yesterday. Are there two other trusts going through an EPR system over the course of the next year? Does that affect us in any way?
York and Scarborough and Harrogate and Caroline are, in fact, they've worked together as well. So I guess from our point of view, they are using a different system, but I think it's back to that sort of shared care record and our sort of role and leadership in that as well, around, how these systems obviously sort of interconnect as well. So yes, we are aware of that. I know Lee and the digital team very much aware of that as well. And obviously we will be thinking about that from an operational perspective, where we've got services, as you know, in that patch too. But I think with all of those developments, you know, we know that people are going to use different systems. What matters is, though, when we're looking at patient pathways, we've got access to the right information at the right time. And I do think the shared care record really puts us in a good position in relation to that.
Great. Okay. Well, it would be good to, as things, you know, progress, is to know what difference it's making. Going back to earlier conversations, because that's going to be really interesting to see a sort of before and after. You know, some of the things people used to, you know, not like about Lorenzo. You know, what's happening now. That'd be really positive, I think, to see and share with staff as well. Their, you know, their experiences. Michelle.
Yeah, no, thank you. And I think it's a really good discussion. And obviously the proof is in the optimisation as well, to be honest. I know that it is really important. But just obviously, I'm sure a lot of us have been around the units and spoken to staff right in the middle of the implementation, and all staff were reacting really well to the new changes, as much as you sometimes can do when you change over from a system. But I just want to thank Lynn really for the leadership on it, because it is something that is a really scary for going through a whole new electronic patient record and going from A to B. And sometimes it sounds really quite straightforward, but it is fraught with real difficulties. And I think the way that it's been structured and the way we've had the pause over Christmas and New Year and the winter, I think it's been really good. And I'm not saying that it's all completed yet, because obviously we've got some of the snagging to do and obviously the optimisation. But I think we will be able to demonstrate the benefits of going to System 1 over the coming months, and we'll look forward to that. But just thank you really, because I know it's been an inordinate test on the top of a busy winter and everything else that's happening as well. And I also thank staff for their patience and things like the floor walkers, etc. So yeah, thank you. And I think at our next meeting we're going to have some more folk that have been involved with it as well, just to say thank you and have a sandwich and what have you. So yeah, and it'll be good obviously the more people go on to System 1, because we can get that interconnectivity as well. Thank you.
Thank you. Yeah, I think echo that to Lynn and also everyone else involved. I think it's our strategic board meeting next time in April. We'll be having some colleagues to come and talk about that, and it'd be good to hear from them. Okay, great. Thank you, Lynn, very much. We move on then to 17, Karen.
Yes, thank you. So this is a report into the leadership competency framework, and this is a relatively similar report to the one that I brought last year, and actually with very little change. So you will recall that in autumn 2023, obviously following the CARC review and various other reviews, that leadership competency, and particularly the fit and proper persons test, was refreshed. And as a result of that, there was the development of the leadership competency framework for board members, including executives and non-executive members of boards. At the time, NHS England published the supporting resources for the chair appraisals, which was very helpful. And there has been a promise ever since that there would be additional supporting resources to support the delivery of wider board member appraisals beyond the chair. We were expecting that soon after, actually, but definitely by autumn 2024, and unfortunately that has not materialised. And very recently we expected it only a few weeks ago, and it hasn't this year. So this paper sets out the implications of the leadership competency framework with a view that we proceed as we did last year. So we developed some in-house supporting resources and forms that we delivered to wider board members, obviously with Caroline as the chair undergoing and using the resources already provided. So we are proposing and recommending that we do the same this year, and I'm currently developing those supporting tools, which will look very similar to how they did last year, but we'll release those for this year's appraisal process. I suppose what I would do is overlay that with the fact that we know, and it's referenced in regulation, and so I am expecting that some of the outputs of that will change maybe the face of the leadership competency framework going forward, but that I'm sure will be revealed in course. So I will stop there and just take any questions.
Okay, anybody question? Do I not fill in our appraisal form then? Do I have something different completely for everybody else then?
You do both, Caroline. So
oh, right, okay, fine.
So
okay.
Yes.
When I read it, it sort of said the NEDs will have the locally agreed appraisal, and mine was, which was, yeah, I wasn't quite sure whether I had something else different to be on my own with.
Each of us have two, so we're very supportive of, and we complete the Humber appraisal form, and then in the background we carry out the assessment in line with the domains.
Okay, so it's really to do with this 360-degree thing that's different for chairs because they haven't sorted that out for NEDs yet.
Yeah, that's correct.
Yeah, okay, all right then. Right, okay, any questions? Okay, I think I've got a meeting set up to just talk about all of this with you, so we're really clear and I can let NEDs know what's happening for them in particular. Great, all right then, thank you very much, Karen. Finance report.
Yeah, thanks, Caroline. So this is the finance position as at the end of February, where as a trust, rather pleasingly, we remained on plan and we're continuing to forecast a break-even position for the financial year. Previous risks that we have reported to the board have all now been closed off, which again is reassuring, and we have a high level of confidence in our forecast position to the end of the year. I think within the paper you can see the ICS position still remains challenging, but as of last week, we are still expected to deliver this year's agreed position, which is an allowable deficit to plan of 34 million, which folk will be able to do with the maths is actually an 84 million deficit plan this year for the ICS. So total, you would expect me today to say this is really positive for us as an organisation, and it puts us in a really strong position as we embark on the planning round that we're in the midst of at the moment and discussing later. So I'll take the rest of the report as read, and I'm more than happy if anybody's got any questions.
Thanks, Pete. Questions to Pete? Golly, okay. Keith?
Not really a question, only to say that I think Pete's very simplistic summary underestimates the amount of work and the importance of delivering a control total in the current environment. So I think we should there's a considerable level of congratulations to the whole team, because that is no mean feat in the current state. And I don't think we should pass by that this year. Next year will be very challenging, and we should congratulate ourselves on that, because there's a huge amount of work to get to that end point.
Thank you, Keith. I'm sure we all agree with that. Thanks. Okay. Right. Thank you very much. We'll move on. Thanks, Pete. Moving on to the performance report.
Lovely. Thanks, Caroline. So again, this is a report as at the end of February. As I often say, we are seeing a similar pattern of performance to what we've seen in previous months. We know what our positive performance is, and we know where some of our hotspots are. You'll note in the paper we are working through, with the EPR transition, some data quality and data reporting requirements, and we've highlighted that, I guess, on the face of the paper. I guess if I was going to pull out 2 points that probably want a bit more of a conversation, sickness remains an area of concern, and I'm sure work we're doing trust across there, and likewise where we are with some performance in that area. So happy to hand over to then go to questions.
Yeah, I think we lifted up, didn't we, Mark, in February? I think that was in the Chief Exec's report, wasn't it? I think 18th of February we were able to do that because there was a bit of stabilisation on sickness absence, I think. Any question? Karen?
Sickness piece particularly, because we can see those recurring sort of trends around high levels of sickness in inpatient areas particularly, and I think I've mentioned before that we have sort of implemented a bespoke and targeted intervention, so operational teams affected working with HR teams in order to really understand what's driving that sickness absence and then look at what those bespoke actions are. We are reviewing the outputs of that within the executive team. Unfortunately, at this stage, we're looking at sort of winter data when we know that it was a difficult winter for a number of reasons. So actually, we're still looking to see that work sort of pay dividends, as it were, but that's ongoing at the moment.
Thank you. Any questions? Comments? Okay. Thanks very much, Pete. Is Oliver with us? Yes, he is. Hello, Oliver. Welcome.
Good morning, Caroline. Good morning, everybody.
We'll go to you for the risk register update, followed by the BAF update. Thank you.
Thank you. So in terms of the risk register, obviously we've reviewed it as a sort of quarter-end position, and this represents the current highest rated risks that sit across the organisation's risk registers. Just in terms of highlights, there's currently 5 entries that sit on the document that have been via EMT, discussed obviously and agreed for the current position, have been discussed via the board subcommittees as well, and obviously landed as this is kind of an end position for the quarter. I think the main highlight, just to highlight on this particular report, is in terms of risks that have closed off since the last reported position, we had one of the workforce related risks, so the risk around the regional workforce reduction scheme has been reduced, currently at a rating that doesn't include it on the trust-wide risk register. It will continue to be reviewed by the Workforce and OD risk register and obviously reported into Workforce and OD committee for ongoing review. And then there's one risk, which is the risk around the ICS and the challenging financial targets, which has been closed off as a 24-25 position, and again rescoped for 25-26, which now appears as a new risk, obviously just so it's more concurrent with the current position, and obviously affords us to have an entry going into the new financial year to obviously keep an eye on and monitor in line with the other risks that are on the risk register. So those are the main highlights in terms of changes. In terms of the overall number of risks across the organisation, since last reported the board in November, we've seen a slight reduction in total number, going down from 155 to 149 total risks. Obviously, that continues to be reviewed. It is a very much a moving position in terms of the risks each month when we review the risks at ODG, and obviously the board reports into EMT as well. So happy to take any comments, any questions at this stage. As I said, obviously those are the current highest rated risks for the organisation for the current version.
Thanks very much, Oliver. Questions or comments? No? OK, let's move on to the BAF.
OK, thank you. So with regards to the board assurance framework, this represents a Q3 position. I think obviously, the previous decision was taken to move around the board reporting frequency, so we're now at 3 times per year. So that's slightly changed in terms of timescales for it coming to board. I think it was originally scheduled to come in January, but obviously that would not allow us to have the full quarter's worth of data. So we obviously pushed it to March position, just so we had that full Q3 standing. So obviously it's been reviewed, it's been via the board committees in terms of obviously assurance for the relevant assuring areas. Obviously we continue to review the template with a view to obviously update it for Q1 in the new financial year as well. But again, obviously representative of that current position at the end of Q3, conscious now we're fast approaching the end of Q4, so we'll be in the process of finalising the next iteration of the BAF. So obviously this has been through the board subcommittees, it has had the level of review, and obviously been to EMT multiple occasions. So again, it does represent a finite position. So I recognise that it may not be in terms of what you'd expect to see as a current position, but obviously we're just closing off that reporting for the end of Q3, and we should look to catch up now in line with the board work plan going forward. So again, happy to take any queries, any questions on that. I think obviously we have had previous comments around kind of individual finite parts influencing the score, but just to iterate that we're looking at a score against each of these strategic goals as a whole. So obviously we're looking at multiple different areas and looking to seek assurance around all of those areas. So it may not always be reflected of the risk register, because we're obviously looking at as part of the approach. Fast approaching the end of Q4, so obviously that next iteration will be developed and will be coming to the board over the next few months.
Thank you very much, Oliver. Any questions on the BAF paper? Michelle?
Yeah, thanks, Oliver, for the work. I mean, I think it's really interesting, just for those listening, that both this and both the BAF and the risk register go through a lot of scrutiny before it actually comes to board. Not just from an exec team point of view, but via the various committee structure. So it's pleasing that those have been answered. I think one of the things that Stuart would say if he was here was around how this absolutely links into our outputs and how it links into our strategic goals. And I think we're getting better with that. But we have got some time coming up at one of our timeouts that Sarah's helping lead with Oliver around how we really structure the format a little bit more. So as Oliver said, it will morph into something a little bit different, but with some of the similar content. And obviously a little bit more around how we just keep some of the data a bit more relevant than what it is. Because I think one of the things Stuart would say is that some of the data needs to be a bit more refreshed and a bit more relevant. So we'll continue to do that as well. But I'm airing that on behalf of Stuart, because I know that that's what he would say if he was here, even though it's been to the audit committee and we've had a lot of conversations about it. Thanks, and thanks, Oliver. Thanks, Chair.
Yes, thank you for that, Michelle. You're absolutely right, Stuart would be commenting on that. Thanks very much, Oliver. So people happy to approve the risk register update, and we just note the BAF. Perfect. Thanks very much. OK, moving on then to Dean, People and Organisational Development Committee.
Yeah, thank you. My assurance report is there. As usual, we had updates from the 3 executive groups that report into us, so the Staff Health and Wellbeing Group, Equality, Diversity and Inclusion, and the Medical Education Committee, and all those continue to be vibrant, doing sort of positive, good work and good engaged people on those. We had a look at the metrics and the KPIs, just pleasing there in terms of reducing vacancy rate now at 7.3%, and also our turnover rate below 10%. And again, as Michelle was saying earlier, real significant improvements over a number of years in that area. Although also good rates of recruitment for consultants, that continues to be a concern. So it's kind of like positive assurance, but work we still need to be doing on there as well. We also are receiving a report on sort of workforce productivity. So this is a developing report, comes to the People Committee and the Finance Committee, but with a focus on productivity. We felt it was important to be looking at what we're measuring and what we understand about the productivity of our workforce. We discussed the risk register and the BAF. We had a great update from the Guardian of Safe Working, reduced exceptions from the previous time. And then we also had an update on mental health and social work in the NHS, some guidance that had come out from NHS England, and we're looking at our implementation of that and work that we'd been doing prior to that in that nature of work. And then we also had just some deep dives, thematic reviews, sort of really getting into the detail of them. Committee really impressed with the papers here and the work that had been done in Karen's team, providing some really high quality data and aiding our understanding. And I know Alison was on here earlier, but we also looked at the toolkit on the freedom to speak up. So just some of the highlights, but happy to take any questions.
Thank you very much. Dean, any questions to Dean? No? Okay, thanks, Dean. Phil, Quality Committee.
Yeah, the Quality Committee assurance report's there for information. It reports on meeting we had on the 19th of February. Pleased to report that today the board received an update from Paul Johnson from the Nottingham reports, and confirmed that Quality Committee will continue oversight of this area and report up to board as appropriate, and board will get intermittent updates anyway. Also, there's 1 or 2 issues around falls, and we've asked for an update again in 6 months' time. And we had a discussion around the presentation of the annual ligature report, and as a result of that, EMT have agreed to look at the risk profile in the estates relative to ligature risk, and they were the key main areas out of that meeting. Happy to take any questions.
Thanks. Any questions to Phil? No, thank you, Phil. Steph.
Thank you. Yeah, we've had one meeting since the last board. On performance, we received assurance in regard to Q3. There were no significant issues. Reducing restrictive interventions. Again, everything was within the expected control limits, and numbers are quite small. However, increase in acuity has had impact on levels of violence and aggression and the use of seclusion, which is there in the report. But as I said, that is within the control limits. Really good report on crisis care, which is a really important partnership that we're involved in Hull and East Yorkshire. Some really good work there on looking at crisis care. So we also received a report on MAPA. We have raised issues with regards to the mental health bill and issues emerging around potential future impact on the trust, and they need to start to consider some of the risks around that and the planning requirements. That has been discussed with Oliver, and I know Kwame's had that discussion with Oliver. It's probably a little bit too early for us to be looking at that, but it's sort of an early flag on the agenda for mental health bill changes. That's it from me. Happy to take any questions.
Thanks, Steph. Any questions for Steph? No? Okay. Obviously, Stuart sent his apologies and that you have the assurance reports there from him. If there's any questions, if you want to put them in the chat box, and we'll feed them back to Stuart. And if he for a reply if appropriate. Keith, was there anything? I know you haven't had a meeting. Is there anything you wanted to say today?
No, just the finance committees in a couple of weeks' time. It's kind of fallen out from a calendar point, because you might remember, Caroline, we were literally about 2 days before the previous board in January. So the meeting is in a couple of weeks' time. We did have an interim meet around budgets and planning cycle for next year, but that's still in progress at the moment. So nothing specific to add, I think, from finance.
Thanks very much. Okay. Moving on then to the April Board Strategic Development Meeting agenda. I've got a feeling that this is got to be further updated, because I think Michelle might help me, and we haven't got Stella today. I think we talked about maybe having something on the community mental health teams and some of the work that's been going on there in terms of organisation. And item 7 is a new one to me. But is that right, Michelle?
Yes, we do.
You remember? Yeah.
Yeah, just a bit more of a service update, really. I'll speak to Lynn, and we've not necessarily decided which area, but we will do something around that. But Lynn was on leave, so and we'll recirculate the agenda.
Yeah, sure. Okay. And as it says on there, we'll be having a sandwich with the EPR colleagues who've been working, which we were talking about earlier. Okay. Anything on that? No. Review of the meeting. You've got the questions there. Have we focused on the right areas? Is there an area we should have focused on? We haven't. Have the papers helped you to do your work here today? I think we've had some good debates and questions raised. And has everyone felt we've done it in line with our behavioural standards framework? No, everyone's been able to have their say. Nobody's felt they've been cut short or anything like that. Any comments? Happy with the meeting? Brilliant. Okay, thanks to everybody who's presented and everybody who's provided a report for today. I think it's now 11:50. I suggest we stop there, and we'll come back in half an hour for our part 2. Is that all right with everyone? So click into the other link. Thanks, everybody. See you shortly. Bye.